While mealtimes are enjoyable social occasions for most people, dysphagia, a swallowing disorder, can cast a dark shadow on even the happiest of meals. A swallow is the entire process of food moving from the lips to the stomach. First, the lips close around the food, and the tongue and cheeks direct food to the teeth, where it is broken down and mixed with saliva. This forms a bolus, or round lump, which is pushed to the back of the mouth, called the pharynx. There, the swallow reflex is triggered. The velum raises to close off the nasal cavity, and the epiglottis lowers to protect the trachea, which leads to the lungs. When the bolus is in the pharynx, it moves down to the esophagus, which leads to the stomach. Wave-like contractions of involuntary muscles, called peristalsis, help move the bolus along. Dysphagia, then, is any inability or difficulty in swallowing. The beginning of the swallowing process may be affected by poor muscle tone in the cheeks or tongue, missing teeth, or inadequate amounts of saliva. Farther back in the oral cavity and pharynx, the epiglottis, vocal folds, or velum may have dysfunctional or incomplete closure, allowing food particles to enter the nasal cavity or trachea. If food does make it into the esophagus successfully, slow or absent peristalsis will lead to an accumulation of food before it reaches the stomach.
Swallowing disorders are not always apparent, so you have to get an evaluation done by an SLP or other professionals on the treatment team. The treatment team consists of a dietitian, an OT, ENT, physician, and radiologist. They all work side by side with an SLP to treat your loved one's dysphagia. There are two types of screenings based on the age of the patient: NICE for infants, and the Burke Dysphagia Screening Test for older patients. NICE is a non-instrumental clinical evaluation that consists of gathering family history, clinical reports, and observing the baby's ability to seal and suck. The Burke Dysphagia Screening Test is a test where the clinician observes while the patient drinks 3 ounces of water without stopping. During and after the water is consumed, the clinician will note if the patient coughed during consumption and whether their voice quality changed. More accurate, in-depth assessments of the nature and severity of dysphagia will follow if there is a problem. The bedside swallowing examination is an assessment where the SLP observes the patient's awareness of food, motor control, and laryngeal control. The instrumental assessments are the modified barium swallow, the fiber optic endoscopic evaluation of swallowing, the scintigraphy, and the ultrasound. The modified barium study is an X-ray procedure by a radiologist to follow the movement of a piece of food containing barium. An ENT can perform a fiber optic endoscopic evaluation of swallowing. The specialist will insert the camera into the nose and into the throat to observe the swallowing function. A scintigraphy measures the amount of aspiration during or after a swallow by following the food that has a radioactive tracer in it. This test is used to show esophageal function. The ultrasound is used to view the oral cavity and thyroid notch to paint a picture of what it looks like inside. Here, specialists can observe the duration of a swallow and the movement of the structures required to swallow.
People with dysphagia should be mindful of certain complications that can occur as a result of the condition. Those with head and neck cancer may not be as receptive to medical treatments and may have issues with wound healing. All have an increased risk of choking, bronchial infections as a result of inhaling food particles, malnutrition, weight loss, dehydration, muscle debilitation, and death from asphyxia. Those with dysphagia are also prone to depression. Nearly half receive the diagnosis, while many others report anxiety and/or panic during meals and when hungry. Others still struggle with the social aspects of their lives, as much of socialization is connected to eating and drinking. Finding other social activities can be helpful to prevent this problem. It is also helpful to keep a quiet environment, free of distractions, for eating to help reduce the anxiety involved. It's important to avoid eating alone to reduce the safety risks and ensure someone is around to help in case of asphyxiation.
Here are some strategies for patients with dysphagia to swallow without any injuries or obstacles. To help you understand more easily, I would explain those strategies with actual postures done by Lindsay. Before knowing about strategies, all patients and their guardians should be aware that the patient should have correct posture before swallowing. Wrong posture may cause patients to choke or have other difficulties while swallowing. The optimal posture per patient is to sit with their back straight and fixed. There are various different ways, and each tactic is intended to facilitate swallowing by either changing postural techniques or conducting compensatory strategies. Postural techniques to facilitate swallowing include following ways: chin tuck, head back chin up, and head rotation. Particularly, head rotation for swallowing varies in how strong or weak the pharyngeal organs are. Patients with unilateral paralysis of the pharynx utilize head rotation either to strong or weak side of the pharynx. Head rotation to the weak side helps bolus flow avoid the damaged part of the pharynx. On the other hand, head rotation to strong side sends the bolus through the functioning side of the pharynx, especially when the patient's oral cavity and/or the pharynx are paralyzed. Meanwhile, one of the most compensatory strategies for swallowing is supraglottic swallow, which should be utilized on parents without many difficulties with swallowing. The helpers commands patients to take a deep breath and hold, and patient swallows while holding his or her breath. Coughing should occur immediately after as a signal of success swallowing. Generally, compensatory strategies for swallowing protects the airway, helping respiration while swallowing.
People with dysphagia will likely need to modify their diets for different textures of foods. The American Dietetic Association, ADA, has 3 distinct categories for these textures: pureed, mechanically altered, and advanced. An example of a pureed food would be a homogeneous fluid, something that's been run through a blender or other food processor. Pudding and non-chunky applesauce will have this texture. Mechanically altered food is moist and semi-solid. Think of cake, cooked breakfast cereals, pancakes with syrup, cheese, ground meats, and egg salad. Advanced foods are the most similar to ordinary solid foods, but still must be softened to facilitate chewing and swallowing. They must also be cut into small pieces. Foods such as meat may be tough but not hard. Dry breakfast foods should be eaten with milk, and lettuce should be shredded. Cooked vegetables are in this category. Liquids are even more difficult for people to swallow if they have dysphagia, and are categorized into 4 levels that increase in difficulty: thin, nectar-like, honey-like, and spoon-thick. Here are some tips on how you can help someone in your home with dysphagia. Keep a blender or other food processor around. Cut and prepare all hard or dry foods. Purchase commercial thickening agents for water and juice. They will vary in strengths, but provide instructions on how much to add. Avoid serving ice cream and jello because their thickness changes with temperature. And be sure to make sure all the food has a pleasing taste, is prepared at the proper temperature, and is nutritious.